For our next presenter for today, we have Dr. David Chesler. He is from internal medicine physician, private practice, Charlottesville Family Medicine, 1980 till present. Diplomat of American Board of Internal Medicine, board certified in geriatric medicine. So Dr. David, welcome. Thank you very much for your insights. Thank you very much for your time. Let's start.
Good morning. I'm Dr. David Chesler. I'm delighted to be able to share with you my experience in treating older patients with COVID-19 in the elder care setting. I've been in practice of internal medicine and geriatrics since 1980, or maybe a couple years before that, in Charlottesville, Virginia. Charlottesville's about a 2-hour drive south of Washington, an hour west of Richmond. It's the home of the University of Virginia and the home of Thomas Jefferson, where he was born and lived. He was the 3rd president of the United States and the author of the Declaration of Independence. Although I have a healthy outpatient clinic, I also have, with the help of nurse practitioners and physician assistants, care for a large number of nursing home residents and assisted living residents in different facilities. Now, I have to admit that last spring was a pretty scary time, probably for all of us. Scary enough that my daughters were insisting that I retire and go find a cave to live in for a while. But that didn't sound too exciting. It was clear that the nursing homes were experiencing large epidemics of COVID, leading to high mortality rates. By April, we had several nursing homes in the central Virginia area who had had mortality rates close to 30%. Following the news and literature, it appeared to me that the focus of the medical community, especially here in the United States, was only how to treat those individuals affected with COVID who had gotten sick enough to get into the hospital. It was a difficult time. It was hard to get PPE. It was very hard to find testing. I didn't feel that that was the best thing we could do for our nursing home population. I thought that some kind of early treatment that might help keep them from getting so sick that they would end up in the hospital and then lose their lives was something that we could achieve. Now, there have been early reports of outpatient treatment with hydroxychloroquine and azithromycin. But there was also some concerns about potential cardiac toxicities. Then I read about the in vitro study out of Australia by Tally, where COVID-infected cells in culture showed a rapid clearance with the use of ivermectin. Now, as it turned out, I'd had a lot of experience using ivermectin in some really difficult to manage scabies outbreaks in the nursing home setting. And I found it to be extremely safe medicine, essentially no side effects. So what I set out to do was put together a regimen that, first of all, I would not expect it to do any harm, and at least would have a basis in theory that would help COVID-infected patients. You can go to the first slide, please. But then it happened. One of the nursing homes I was covering was infected with COVID. Next slide. So what we did was, let me get where I can see these slides too. The homes that I covered included in this study, 2 assisted livings and 5 nursing homes. One was an intermediate care, which generally did not do any IV fluids. And then there were 4 skilled nursing home facilities. Altogether, we're dealing with 513 high-risk residents, 309 PCR confirmed cases, and what I used was a multi-drug approach. Next slide, please. And this was the regimen that I came up with. Vitamin D3, 2,000 units, vitamin C, 1,000, and zinc, 100 milligrams. And the plan was to do this for 3 weeks. I added to that enoxaparin, 40 milligrams sub-Q for 3 weeks. And this is prophylactic dosing. And then to that, I added ivermectin, 12 milligrams a day on days 1 and 8. And that was the same dosing that I was used to using in the nursing home with the scabies. And it proved to be safe. And like I said, no harm was our goal. And also doxycycline, 100 milligrams twice a day for 10 days. And that was in facilities 2 through 7. Now the numbers have to do with the order in which they developed. It turned out I never had more than 1 facility with the COVID outbreak at one time. The only difference here was that in the very first facility, we used azithromycin, 500 milligrams daily for 7 days. So we sort of took the hydroxychloroquine azithromycin regimen that some people were promoting, got rid of the hydroxychloroquine, and just added ivermectin to that. Next slide, please. So let's look at the first facility. This was an intermediate care. Like I said, they generally did not use IV fluids there. It was a 30-bed facility, part of a life care community. We ended up with 100% positivity. The average age, 87.7 years. And I divided it into 2 groups, early and late. And this had to do with how we were able to test these patients. In the early group, there were 6 patients. We really had to scrounge around to find testing kits. One individual was an end-stage dementia with failure to thrive, and he expired. His goals of care were to not use IV fluids, and we respected that. It was really 8 or 9 days before we were able to test anybody else. I was convinced that the facility was going to have a lot of COVID because one of the women in the first group was a very ambulatory, though demented individual. And I kind of assumed she was carrying COVID around to everybody before we were able to find out that she had it. And that proved to be the case. Now in that late group, and the other thing I would mention was that I did not want to start treatment until I knew that we had a confirmed case. Now there were 19 patients that received the regimen, and there were 5 patients who didn't, and these were patients for whom I was not the attending physician. One individual was a 104-year-old lady that had a stroke and passed on. In the non-treatment group, there was one individual who passed away. And in the 19, including the stroke patient, there were 3 others. And these were all failure to thrive, end-stage dementia, dependent on all their ADLs. And the families did not want us to use IV fluids. I had talked the facility into using Clysis if it became appropriate, but we didn't use it. Next slide. So, but the lessons I learned in this first facility was that testing early meant earlier treatment and better results. The only person that I had sent to the hospital in that early group was someone who developed profuse diarrhea, and he ended up in the ICU for about 8 days and came back to us, and he's still doing fine. And I thought the hardest thing to tackle was the anorexia, which usually started coming on in the 2nd week. And nursing had to really work hard to encourage people to eat and drink and to keep them hydrated. I might add that nobody developed acute hypoxic respiratory failure. Number of people used some low flow oxygen, but that was all. Next slide. The first facility was, the infection started in late April. Facility number 2 showed up in June of 2020. This was an assisted living facility. There were 57 patients. We ended up with 63.2% positivity. There was an average age of 80.7 years. The first individual, the index case, was someone we thought was probably uroseptic. She was obviously very ill. We sent her to the emergency room, and there she tested positive for COVID. So now we knew there was COVID in the building. The first thing that I did was I placed the entire facility on vitamins and zinc. Next slide. Let's go to the next slide, please. So all in all, we had 36 positives. There were 4 deaths early on. None of these people were able to have gotten any treatment at all, actually. 2 of these ended up on respirators, and both subsequently expired. One was being the index case. And there were 2 others who were already at the end of their life in hospice, and they passed on before they could get any kind of treatment. You have to remember that in all these facilities, you don't have in-house pharmacies. Plus, the pharmacies weren't all geared up to have ivermectin. So there was often a delay of a day or 2 before we could get the ivermectin in after I ordered it. All of the 32 patients who were treated survived. We did have testing done weekly. Things were getting a little better on that score. And here I'd switched over to the doxycycline. That and the ivermectin and enoxaparin were started as soon as a patient became positive. Over the course of several weeks, a few people did get dexamethasone when their SAT started to drop or get wheezy. All in all, good experience. Next slide. The next facility, I'm going to skip 3 and we're going to come back to it. Number 4 was a small assisted living facility. There were 15 patients. 10 of these were positive, which gave us a 66.7% positivity, average age of 84.7. There were 8 survivors. 2 of the patients who died were really end stage, end of life, failure to thrive, dementia on hospice. And they'd actually quit eating about 2 weeks before COVID got in the building. And they expired. Whether they died with COVID or because of COVID, of course we won't know, but I think it was really that they died with it. Next slide. The next facility, number 5, was a skilled nursing facility. It's one of the ones that I'm actual medical director of. We had 92 patients in the facility. We had a 29.3% positivity. The average age was 78.2. So we had 27 positives. The first person in the facility to get COVID was actually a staff member. And at that point, we started the ivermectin, excuse me, the 2 vitamins and zinc, and then waited for the PCR test to be done. So there were a total of 27 positives. 24 were my patients, and so they all received the regimen. There were no deaths. And there were 3 who were taken care of by another physician, and they did not have any of theirs die, but 1 was on ECMO for a good while in the hospital. Next facility, next slide, please. This is number 6, 90 patients. Again, a SNF, and again, I'm medical director at this facility. 27.8% positivity. I think we did a really good job in both of these facilities in containing the outbreak. The average age was 81.2 years. We had 25 positives, all of whom who received the regimen. Again, as soon as there was word that a staff member had because it always seemed to be the staff that they were positive. Then the whole building was placed on the vitamin C, the vitamin D, and the zinc. We had 23 survive. There were 2 deaths. One was a gentleman who'd been on comfort care for 4 months. He did get the regimen, but we were not permitted to use any IV fluids, and we lost him. And there was one other gentleman who was a brittle diabetic. He was initially doing pretty well. His saturations were all good, and he was found to have expired in his sleep about 3 in the morning. And I suspect it was from COVID. Next slide. So let's get to number 3. This one actually occurred in July. It was this was a facility with 132 patients. There were 90 patients became positive very rapidly. The average age was 77 years. The oldest resident was 106 years old. 3 patients died early before the regimen could ever get started. Next slide. And I'm going to divide it into 2 groups. Myself and one other physician cared for pretty much all the residents in the facility. Now, in my group, I had 58 total patients. There were 39 PCR positives, or 67.2% of the patients, and they were all treated with the regimen. In that group, I had 2 deaths. One was a 100-year-old fellow with renal failure, and one was a fairly demented individual, not on hospice, but when she got into the 2nd week and the anorexia set in, she wouldn't eat. It was hard to get her to drink anything, and the family declined to give her any IV fluid support. This gave us a mortality rate of 5.1. The 106-year-old required IVs for about 4 days, and by that time she was able to start eating and drinking well, and she continued, and finally we finally lost her a couple months ago, but she survived COVID. Next slide. Group 2, and I'll refer to this as Dr. A's group. We had 74 total patients. He did, and there were 51 positives for a positivity rate of 68.9%. But he had 17 deaths. Remember, I had 2, so he had 17 deaths. And I'm dividing these into how they were treated. He began using the regimen, and then some other physicians talked him out of using it, declaring that there was no evidence and this was not standard of care. He fell for that. And so after about 4 days, some of the patients that had been started on the regimen were stopped. And then after that time, none were started as they became positive. And partial treatment for most of them consisted of 1 dose of ivermectin and 3 or 4 days of the doxycycline. His mortality rate was 33%. Next slide. There was one other facility. This is the 7th one, and it was kind of like running the marathon and then tripping in the last 100 feet. We were almost to the vaccine, and in late December, COVID entered the building. There were 94 patients in the facility at that time. They ended up with 88 positive cases, the average age being 81 years. There were 93.6% positivity. Next slide. And again, I'm going to divide this into 2 groups. Now, it turns out in this facility there were 4 providers, myself, who had the majority of the patients, and then 3 others. And one of the providers that I'll refer to as Dr. B followed my regimen. So between us, we had 65 positive cases, all of whom received the regimen. There were 2 deaths. One was an end-stage dementia hospice patient with failure to thrive, and then one was a fellow who of mine who had entered the facility initially as a respite from hospice. He had metastatic lung cancer and had already survived a lot longer than we had expected, but we lost him during this time. This gave us a mortality rate of 3%. Group 2 were the 2 other physicians. They had 23 positives, and none were treated with anything other than what I call first aid, which was low flow oxygen as needed, Tylenol, and encouragement. That group had 5 deaths, which gave them a mortality of 21.7. Next slide. So in summary, I had was caring for 513 high-risk residents. There were a total of 309 PCR positive cases in 7 different facilities. The focus was on early treatment. As the months went by, it became easier to get the treatment done, and we could test weekly or even bi-weekly. Although I would admit that in that last case, the last facility, number 7, it became clear that getting into the end of 2020, there had been 16 cases, and I knew it was going to spread throughout most of the facility, which it did. And on New Year's Eve, I made the decision to go ahead and begin the ivermectin and doxycycline and enoxaparin. So I did jump the gun there a little bit. And then when the next round of testing came on January 4th, the numbers just started to pile up. And then the next testing was on January 8th, and then there were further ones down the line. So some patients actually did get the ivermectin and doxycycline started in advance. Next slide. So the 2 facilities with multiple providers sort of created a poor man's control study. There were 229 residents with 181 positive cases, 152 resolved. There were 29 deaths. So if we look at mortality by treatment, those that received the full regimen, 3.8% were lost. If they got the partial regimen, gave us a mortality of 16.7. That, and partial again meant 1 dose of ivermectin and 3 or 4 days of doxycycline. And those who received no ivermectin or doxycycline, 37.3% mortality. And that's my experience. There were a couple of facilities that had some further outbreaks. Facility number 1 and facility number 3. One had 5, one had 6. They all received the regimen, and we had nobody expire. So I'll open it up for questions, and I thank you all for participating in this conference and showing interest in early treatment of COVID, especially with the use of ivermectin. Thank you.
So Dr. Chesler, thank you very much. The thing that I noted, so of course, being a medical doctor, I was also very much interested in seeing the regimen that you were using, but the bravery that you decided to start using it, and then your team started using it, and then the results that we are seeing here, such a wonderful step that you took and saved lives. I have lots of questions here. So let's start one by one and see how far we can go. So first of all, let me go from the questions that are here in the window. Let's start with Merelli Fanos. They say, Dr. Chesler, thank you for having the courage to save your patients. I sincerely hope that your information and that of the other brave physicians will be shared, as is the case in the bird group. So the question for you is, would this be the information that you provided here available somewhere? Is there a protocol that you have developed during this process?
Well, several of the people in the Baird group are working with me to try to get this published. Hasn't been that easy. We were rejected first time, but we've made some changes and we're trying to get it out. Early on in January, I had sent most of the data up to the NIH and never heard anything back from them.
Got it. So one more question from Mike Muldoon. So Dr. Chesler talks about use of ivermectin and vitamins. What vitamins did he use? I heard about vitamin C, vitamin D, and zinc. Are there any other vitamins or supplements that would have helped in healing multivitamins? So did you have a specific regimen with these vitamins?
No, those are the ones I started with and I stayed with them. There were other things that people were starting to use, like famotidine or colchicine. The thing was that the regimen kept working, and I just didn't see any reason to change it. And every time a new facility would get infected, I would worry if the magic was going to work again. And it always seemed to. And the thing that was important to me was that nobody ended up in really bad respiratory failure. I didn't have one person who got the regimen end up on a respirator.
Got it. So this is then leading into this next question, and I'm going to collate two questions here. One question is about your own staff and their prophylaxis. Were you using ivermectin as a prophylaxis, your staff? And I'm going to add one more question here as well, and that is in a similar line. How long can I take ivermectin if I am caring for an infected intubated patient? So they have been using ivermectin, 1 tablet 3 days straight, 2 tablets when admitted with the patient in the hospital for 3 days. Should I still continue to take ivermectin? So can you help us with the prophylaxis and approach to that?
Well, my staff and I did not use ivermectin prophylactically. We were fortunate. We were able to have enough PPE to keep ourselves protected. I do know a few people who have been using ivermectin, and they've been taking 12 milligrams on a weekly basis. But in our area in Virginia, there are 2 hospitals, and the 2 hospitals are not at all interested in ivermectin. A few people have we've talked about it, but the corporate structure is such that they don't want to promote it.
Got it. And that is another question as well here, that were you, and there are lots of questions, Laurie, Dr. Laurie, you will have to guide me if we should be wrapping up. I think that there is a lot of good information that Dr. Chesler can help with the doctors as well. So may I continue to ask some more questions?
Well, I think we do need to start wrapping up. But what I would like to say to everybody is that we have Dr. Chesler's one of the first clinicians on the program. Tomorrow we have many more clinicians who can also assist with answering questions about dosage and other, more sort of patient-centered questions. So I think if Dr. Chess is happy to wrap it up, they will take one last question perhaps. And then we'll wrap it up. What do you think, Naveen?
Perfect. I think that is perfectly fine. So one question that is interesting is I'm going to collate 2 questions here. One is the use of dexamethasone, or did you use inhaled corticosteroids as well? And what was your approach, early use, late use? And the second, I think, is very important, and that is side effects of ivermectin. Did you see any contraindications or side effects?
No, we didn't. There was one person that was on warfarin, and so she stayed on that, didn't use the enoxaparin, and like I do with any new drug, we just start checking the INRs a couple times a week just to make sure that it's not going to have any side effects, because there's the potential with ivermectin, like with other drugs, to enhance the effects of the warfarin. And what was the other?
So one was the side effects, and the other one is the steroid use. Did you use the steroids early on, later on, inhaled, not inhaled? How did you?
We used dexamethasone, and we used 6 milligrams a day for 7 days. And we did that in people whose saturation started to fall, or if they started to get wheezy. There were a number of the patients had COPD as one of their comorbidities, and if they started to wheeze much, then we went right to the dexamethasone.
Got it.
It was just surprising that especially like the second facility, which was an ALF, we had very little respiratory. I think I mentioned that we used dexamethasone only 2 times.
Got it. So Dr. Chesler, thank you very much for your very, very fascinating discussion, because geriatric population is actually at a higher risk, and then be able to work with them with ivermectin and have such wonderful results, that is exceptional. Dr. Laurie,